So my name is Darren Birch, and I'm Physician Outreach Liaison for Legacy, and I work on a great team of 7 of us who cover all of the programs and hospitals for Legacy Health. And today I have the astute privilege of introducing Dr. Reddy, our heart failure cardiologist program medical director for Legacy. And this is talk 2 in a 4-part series. You can see last month's talk on YouTube. In the email, the reminder email I sent out this morning. There's a link to that YouTube video of the talk for last month. All these are CME accredited for the live events, not for the recorded events. But so you'll get CME credit for this live event, and we'll show you how to do that. And we'll also post in the chat field links and information how you can claim your CME credit. So I will also, please, during this talk, feel free to ask questions in the chat field. We'll get them. We'll get to them during the talk, and so please feel free to do that. We are recording this, of course, so just please keep that in mind. And I'll turn it over to Dr. Reddy. And sorry about the little technical difficulties. So thank you.
Thank you for being here. And this is the part 2 of our 4 webinar series. And last time we talked about specifically Arnie's and SGLT2s. And this is about updates in heart failure with reduced EF or chronic systolic heart failure. So I would like to concentrate mostly on the last few slides, which is the crux of our discussion. So let's zip through some of the information here. So these are my disclosures. I have no disclosures for this talk. The learning objectives of this talk are why quadruple therapy and not triple therapy, and explain the role of IV iron in systolic heart failure. And I originally put down the 2021 expert consensus decision pathway for optimization of heart failure as one of the objective goals, but I think we have time limits. The whole presentation is 45 minutes, and I thought I'll finish in 35 minutes, and we'll have 10 minutes of question time. So probably we'll cover that at some other time. And this is how you get your CMEs. And for any questions, please email Darren Birch. And also there is an email at the bottom of the message slide. So I'll pose 3 questions to you at the beginning of the discussion, and we'll come back to the answers. So you will have about 35 minutes to think about the answers to these 3 questions. So what percentage of eligible patients with heart failure with reduced EF are simultaneously prescribed some form of ACE or Arnie or beta blockers or MRA? So what percentage of people that we treat get all these 3 medications, and which is called triple therapy? So that's question number 1. And the question number 2 is what percentage of eligible patients with heart failure with reduced EF simultaneously prescribe the target dose of ACE or Arnie or beta blockers or MRA. So basically what I'm asking is there is a maximum tolerated dose and there's a target dose. Example, metoprolol succinate, the target dose is 200 milligrams a day, and maximum tolerated dose can be anywhere from 12.5 daily to 200. So the question is what percentage of people that we treat with heart failure get the targeted dose? And what percentage of eligible patients with systolic heart failure have a documented absolute contraindication for any of the 3 therapies, ACE or Arnie, beta blocker, or MRA? So those are the 3 questions, and we'll come back to the answers for these at the end of the discussion. So these are the medications for heart failure with reduced EF or chronic systolic heart failure. The established ones are on the left side of the slide. Diuretics, ACE, ARBs, beta blockers, mineralocorticoid receptor antagonists. These are the spironolactone and eplerenone, hydralazine isosorbide dinitrate combination, and digoxin. Those are the established ones. And now, what are the new ones? The newer medications are ivabradine, not so new, has been there since 2010. but still most people don't know about this. Arnie came out in 2014, trial, Slt2 inhibitors. The evidence has been piling up, and now they are one of the disease-modifying agents. And guanylate cyclase stimulator. So this was FDA approved in January 2021. And cardiac myosin activator, the trial was published in January 2021, phase 3, and we are not sure where we are with regard to FDA approval on this. And intravenous ferric carboxymaltose for patients with heart failure. So that has been there for a while, back and forth. So established heart failure medications, just a quick reminder: diuretics, beta blockers, ACE, ARBs, MRAs, hydralazine, and isosorbide dinitrate. All those 5 categories all have class 1 indication in patients with heart failure with reduced EF. Beta blockers, ACE and ARB, MRAs, hydralazine, and isosorbide dinitrate, they all have mortality benefit. Digoxin has a class 2 indication for reduction in heart failure admission, but it has no mortality benefit. So this is a table which will, you can look at it at your leisure, but all I want you to focus is on this number needed to treat. So if you look at ACE or ARB, you need about 26 patients. You need to treat 26 patients with whichever ACE or ARB you choose for over a period of 36 months to save 1 life. Look at beta blockers, it's 9. And MRA, which is a spironolactone or a eplerenone, 6. You only need to treat 6 patients to save 1 life. And hydralazine nitrate combination, you need to treat 7 people. So all these have track record, have had track record, not only for mortality, but also for reduction in hospitalization. And when we send patients home on diuretic, is furosemide better than torsemide or torsemide better than furosemide? So this is meta-analysis. And as you can see on the x-axis, you have hospitalization due to heart failure, improvement in functional status, all-cause mortality, cardiac mortality, and medication side effects. And this is the percentage. And the blue is torsemide, and red or pink is, or brown is the furosemide. So if you look at column 2, improvement in functional status, torsemide trumps furosemide. So there is definite improvement in functional status with torsemide compared to furosemide. And then if you look at the hospitalization due to heart failure, and less hospitalization with torsemide compared to furosemide, but not statistically significant, but closer. And this aspect here is cardiac mortality. The events are small numbers, so I don't think we should take this very seriously at this time, but at least know that torsemide may prevent some cardiac mortality. But mostly the most of the benefit is in improvement in functional status. They feel better. There are 2 randomized control trials which are waiting to be completed, Tornado and Transform HF. We'll see what those will tell us. So we'll get on with the newer agents here, ivabradine. So why do we need to know ivabradine, and what are the implications of a patient with heart failure having a high heart rate? So in patients with coronary artery disease and left ventricular dysfunction, heart rate of equal to or greater than 70 compared to a heart rate of less than 70, they have 34% higher risk of cardiovascular death. 34% higher risk of cardiovascular death in patients who have had a heart rate of 70 or greater than 70 compared to those with less than 70, and a 53% increase in hospitalization for heart failure. So heart failure reduction does improve these outcomes. Hence, we need to know the implications of increased heart rate and the role of ivabradine. So what does ivabradine do? It lowers the heart rate by inhibiting a funny channel current in the SA node. So it decreases the heart rate, basically. So what's the evidence for ivabradine? This is the name of the trial, the SHIFT clinical trial that was published in 2010 in Lancet. So it was a multinational randomized double-blind placebo-controlled trial. They had patients with heart failure with reduced EF less than 35%, and resting heart rate of equal to or greater than 70, and hospitalization in the last 12 months. And 90% of them were on beta blocker, 90% of them were on beta blocker, 93% were on ACE and ARB, and 60% were on MRAs, and 22% were on digoxin. And they were looking at cardiovascular death or hospitalization for heart failure. It was a large study, 3,000 plus patients in the ivabradine group, 3,000 plus patients in the placebo group. So I want you to focus on panel A, and the x-axis is the time in months, and the y-axis is the primary outcome, which is either cardiovascular death or hospitalization. So the red is the placebo group, and the blue is the ivabradine group. So there was a benefit, statistically significant benefit, in patients who were placed on ivabradine with regard to either cardiovascular death or heart failure hospitalizations. But when they split the outcome into heart failure hospitalization and then cardiovascular death, there was not much benefit with cardiovascular death, but there was a big benefit in the hospitalization for heart failure. So based on this study, based on 2017 guidelines, ivabradine has a class 2A indication for reducing hospitalizations in patients, specifically in patients who have an EF of less than 35% or equal to 35%, and are in NYHA class 2 to 3, have normal sinus rhythm. I underline this, normal sinus rhythm. You can't use in patients with AFib, and on guideline-directed therapy, and who are simultaneously getting a beta blocker at max tolerated dose. And the heart rate, resting heart rate, is either 70 or greater. So those are the patients who will benefit from ivabradine. And what does it do? It reduces the hospitalization in patients. So the next medication is angiotensin receptor nephrosyllane inhibitor. The only Arnie that we have at this time is sacubitril and valsartan. And it has two components. Sacubitril is the neprilysin inhibitor, and valsartan, as we all know, is an ARB. So this is the mechanism how an Arnie works. This is the renin-angiotensin system. This is the natriuretic peptide system. So valsartan, which is here, it prevents the binding of angiotensin 2 to the angiotensin 1 receptor, and thereby it causes, it lowers the blood pressure, it decreases the sympathetic tone, it decreases the aldosterone levels, and decreases cardiac fibrosis or hypertrophy. So it basically helps in remodeling of the heart, decreases aldosterone and sympathetic tone. So what does the sacubitril part do? It prevents the degradation of BNP, which is naturally produced in human body, and increases the levels of BNP, and which then help reduce the blood pressure, help reduce the sympathetic tone, help reduce the aldosterone levels, and help remodeling of the heart, and also increase sodium excretion. So what's the evidence for using Arnie? Paradigm HF. This was published in NEJM, September 11, 2014. It's a randomized, double-blind, multi-center trial. And they compared sacubitril valsartan to enalapril. And there were 4,000 plus patients in the sacubitril valsartan group and 4,000 plus patients in the enalapril group. And the median follow-up was for about 27 months. And what did they find? These are the takeaways from Paradigm. So treatment with sacubitril valsartan compared to enalapril resulted in the following statistically significant outcomes. Number one is it reduced cardiovascular death, it reduced heart failure death, it reduced death from any cause, all-cause mortality, and it improved quality of life. So decrease in cardiovascular death, decrease in heart failure hospitalization, decrease from all-cause mortality, death from any cause, and improving quality of life. But it also caused hypotension in about 17% of patients with who received sacubitril valsartan compared to 11% in those who received enalapril. But the authors say that the hypotension rarely required discontinuation of therapy. That's something to note. Okay, so what are the indications of Arnie? 2017 heart failure guidelines. Arnie has a class 1 indication for treatment of stage C, heart failure with reduced EF in the outpatient setting. And based on 2021 decision pathway, Arnie is preferred to ACE or ARB. I repeat this, based on 2021 decision pathway. This was published in JACC in February 2021. Arnie is preferred to ACE or ARB. So basically, Arnie is first-line afterload reducing agent. That brings us to the Sglt2 inhibitors, the sodium glucose cotransport 2 inhibitors. So there are several mechanisms by which these medications act. So this is an image which tries to put all these mechanisms in one picture. So that's the Sglt2 inhibitor, and that's the kidney, and that's the heart. And on the kidney, it works through the sodium hydrogen exchanger or an exchange pump and the Sglt2 receptors, which are present in the proximal convoluted tubule. In the heart, it works on the sodium hydrogen exchanger, which is located in the cell membrane of the myocardial cells, and it also produces its effects on the heart through producing more ketone bodies. We don't have much time to get into this, but a topic for a different discussion, day for a different discussion, but that's how it works. And in the kidney, it increases the excretion of glucose, it increases the excretion of sodium, it causes the afferent arteriolar dilatation, and it causes hemoconcentration. In the heart, it decreases the fibrosis. So basically reverses the remodeling. It decreases the wall stress, decreases the hypertrophy. So what do all these things result in? They result in improved blood pressure, decreased weight, reduced risk of heart failure hospitalization, and decreased cardiovascular mortality.
Dr. Reddy, we have a question. How does the cost of the newer agents compare to the older agents?
Yeah, the newer agents, the Sglt2, the ivabradine, or Arnies, they're all expensive. But Arnie, I think I had trouble getting authorizations 2017, 2018, but it has become very easy now. They have programs through their industry. And Sglt2s, they give you a 30-day free supply, and some of them give 14-day free supply. And you can still work through industry people to get discounts.
Yeah. There's also another question. Have they studied, or are they going to study Sglt2 inhibitors in heart failure with preserved ejection fraction?
So not yet. Maybe something on the horizon, but not yet.
Thank you.
Okay. So then what's the evidence for Sglt2 inhibitors in heart failure with reduced EF, irrespective of their diabetes? So there are two landmark trials, the DAPA-HF, this was published in NEJM November 21st, 2019, and the other landmark trial came out last year for Emperor reduced. October 8th, 2020. So dapagliflozin was used in DAPA-HF, and empagliflozin was used in EMPEROR-reduced. And meta-analysis from these two trials, meta-analysis from DAPA and EMPEROR-reduced, have shown a reduction in heart failure hospitalization, reduction in cardiovascular mortality, reduction in all-cause mortality, and improved renal outcomes. I'll go over this again. Reduction in heart failure hospitalization, less heart failure hospitalization, less deaths from cardiovascular causes, less deaths from any cause, and improved kidney function. So Stlt2 inhibitors, what are the indications? These we are still waiting for guidelines from ACC and Heart Failure Society, but FDA has approved SGLT2s, the dapagliflozin, and I'm not sure where we are with empagliflozin, but I won't be surprised if it is already there. So it's indicated in heart failure with reduced EF, with EF less than 40% or equal to, plus type 2 diabetes, not type 1. Type 1 is a contraindication. Type 1 is a contraindication. NYHA class 2 to 4, along with guideline-directed therapy, which includes Arnie, beta blocker, or MRA, and the cutoff for eGFR. This is an ongoing discussion. Please, this is my recommendation. This is what I do. When I use dapagliflozin, I do not prescribe for patients with eGFR less than 30 milliliters per minute, because all those patients in that trial were excluded. And if I'm using empagliflozin, I don't use it in patients with eGFR less than 20 milliliters per minute, because those were excluded in the clinical trial. So the starting dose for dapagliflozin is 10 milligrams. There is no up-titration, and please avoid in patients with GFR less than 30 ml per minute. The decision pathway from 2021 says use with caution. And empagliflozin, the starting dose is 10 milligrams. There is no up-titration. Patients with GFR less than 20 were excluded. Again, the decision pathway from 2021 says caution. Now that brings to the a third or the fourth drug. This medication was approved by FDA for use in heart failure with reduced EF in January of this year, and it's called vericiguat. Similar medication has been in use for pulmonary hypertension, I think, for the last couple of years or so. So this is how it acts. What is this drug? This is a stimulator of guanylate cyclase. It's a guanylate cyclase stimulator. So what is guanylate cyclase? It's an enzyme which is located in the myocardial cells and the vascular cells of the human body. So what happens normally is nitric oxide is produced through the action of nitric oxide synthase in the endothelial cell, and the nitric oxide that is produced diffuses out of the endothelial cell into the vascular smooth muscle cell. That is where the guanylate cyclase is located, and it stimulates the guanylate cyclase enzyme, which then converts GTP to cyclic GMP, and cyclic GMP is then involved in multiple cellular reactions, which are essential for cell biology. That's the normal pathway. So what happens in heart failure? There is endothelial dysfunction due to oxidative stress or inflammation. So there is very little nitric oxide is produced. And so there's nothing to stimulate this enzyme. So there is decreased production of cyclic GMP. And when there is decreased production of cyclic GMP, that causes myocardial dysfunction and vascular dysfunction.
So there's a question. Do you have a preferred SGLT2 inhibitor? If so, which and why?
So I don't have a preference, but this is what I would say. I favor empagliflozin over dapagliflozin because people were a lot more sicker in that group, and then it also allows you to go down to an eGFR up to 20. So those are the two reasons. And there were, I think if I remember properly, there were 72% of their study population had EFs less than 40%. But there were definitely more patients with severe LV systolic dysfunction compared to data, plus the eGFR. And so that's how it works. The variciguat, it stimulates the guanylate cyclase enzyme and produces more GMP, and that's how it helps myocardial function. So Victoria trial, it was published in last year, and the primary outcome was cardiovascular death or hospitalization. As you can see, number needed to treat is 24. So based on this, it was approved for these reasons, approved for patients with heart failure with reduced EF, LVEF less than 45%, and NYHA class 2 to 4. The people who have had hospitalization in the last 6 months or received IV diuretics in the last 3 months and simultaneously have been on GDMT. So we are looking at a lot sicker patients. And watch for hypertension, syncope, and anemia, and concomitant use with PDE5 inhibitors, which is sildenafil, can result in worsening hypertension because they work in similar pathways. Patients with eGFR less than 15 were excluded. And that brings us to our last medication, our second last medication. So this is called omecamtiv mecarbil. This is cardiac myosin activator. And this is how it works. You have two filaments, myosin filaments and actin filaments in heart muscle. And they have to interact with each other to produce an effective contraction. And effective contraction produces an effective systole. Effective systole causes effective stroke volume, right? So in heart failure, the interaction between myosin and actin is weak. And what does this medication do? It actually improves that interaction by producing more energy. And that improves contraction translates into increasing systolic ejection time and increased stroke volume, but does not increase the heart rate and does not increase oxygen uptake. That's how it works. So Galactic HF was published in January 2021, and primary outcome, hospitalization for heart failure or an urgent visit for heart failure or cardiovascular death. So there is a difference between placebo group and the drug. So it's a positive trial. Like I said, I don't know what's happening with the FDA approval, and I won't be surprised if it gets approved. And this is a note about IV ion therapy. Based on 2017 ACC guidelines, it's class 2B. And this is the algorithm, how you want to use it. So for patients with symptomatic heart failure with reduced EF, NYHA class 2 or 3, you check their hemoglobin. If the hemoglobin is less than 15, if the answer is yes, then check their ferritin. If their ferritin is less than 100 micrograms per liter, then consider IV ion therapy. If their ferritin is between 100 and 299, check for transferrin saturation. And if that is less than 20%, give it. But if they have significant anemia, we have to initiate anemia evaluation, which is colon cancer, upper GI bleeding, lower GI bleeding, or pelvic bleeding, or bleeding from anywhere. So while you're doing this, this is how I do. I use this algorithm, but I also intimate or inform the PCPs, hey, we are doing this, but please look into doing a colonoscopy or EGD or pelvic examination. Just make sure that you rule out the other causes. And I think this picture summarizes the whole discussion here. So I want you to focus on the x-axis here, which is risk reduction in sudden cardiac death. And on the y-axis is 3-year number needed to treat to prevent one sudden death. So we talk about ACE, it needs so many patients. But if you look at here, beta blockers, MRAs, and Arnie, that is the triple therapy. You get about 30 to 40% risk reduction, and you only need anywhere from 10 to 30 patients to prevent that sudden cardiac death. So triple therapy, triple therapy, triple therapy. That was the message up until 2019, 2020. And now this is the message. So it's triple therapy transformed into quadruple therapy, or if you want to call 4 pillars of pharmacotherapy for heart failure with reduced ejection fraction. So right in the middle is the patient with heart failure with reduced EF. There's an inner circle, there's an outer circle. The components of the inner circle are the foundational disease modifying therapies. They are the first line therapies. They modify the disease course. The therapies in the outline, outer circle are additional therapies in special situations. So what are the 4 pillars? Renin-angiotensin inhibition and neprilysin inhibition, that's pillar 1. Pillar 2 is sympathetic nervous system inhibition, which are the beta blockers. Aldosterone inhibitors are the MRAs, spironolactone or eplerenone, and Sgt2 inhibition. So if you look at this and review this in conjunction with 2021 decision pathway, Arnie is preferred to ACE or ARB. So that's pillar 1, beta blocker, MRAs, and SGLT2s. And the outer circle are the ones for special situations. For African Americans, use hydralazine isosorbate dinitrate. Patients where the heart rate is not controlled despite guideline-directed therapy and beta blocker maximum dose, use ivabradine. And sicker patients use vericiguat. And patients with low ferritin use IV iron therapy. And we are still waiting for FDA approval on the myosin activator. So having said that, so we'll go back to our questions, right? So what percentage of eligible patients with heart failure with reduced EF simultaneously were prescribed the triple therapy? Any takers?
You can either put in the chat or you can unmute yourself.
So in the interest of time, I'll give you the answer. 22%. So 1 patient in 5 with heart failure with reduced EF gets some form of triple therapy. 1 in 5. 4 out of 5 people are not getting treated. So what percentage of eligible patients with heart failure with reduced EF are simultaneously prescribed the target dose that was used in the clinical trials, right? 1 in 100. 1 in 100.
We had one guess of 0, so
that's
close.
Close. And then we say, oh, wow, this patient doesn't tolerate this. This patient doesn't tolerate that. That's why I haven't given it. So let's see. What percentage of eligible patients with systolic heart failure have a documented absolute contraindication? Absolute contraindication. You cannot use it, right? What percentage? Less than 2%. So more than 98% can tolerate. Only 1 in 5 gets some form of triple therapy, and 1 in 100 gets the target therapy. So something to think about. And I'll pose a question for you. So for all of us, including me and our team, is, are we really providing optimal care for our heart failure patients? Are we truly helping reduce their morbidity and mortality? We talk about sudden death, decreased lifespan, heart failure readmission. So if we are only giving if only 1 in 5 patients is getting some form of triple therapy, and only 1 in 100 is getting targeted therapies, are we really doing any service to these patients? If the answer is no, we are not doing, then we are here to help you with that. So this is our legacy heart failure clinic structure. I'm the medical director, and Lena Rossetti Grolich is our heart failure nurse practitioner. Susan Bladen is our heart failure RN. Charles Griffith is our heart failure MA. Miranda Meng is our heart failure social worker. And this is just the one number you need to call from 8 to 5 or 8 to 4. You can leave a message. It's a heart failure direct line, 503-413-4187.
So we have a question, but Dr. Reddy, if I can have you go to the very last slide. I added a couple slides. Just go to the last one.
This one?
No, go further down, like, yep, right there.
Okay.
So just before we get to the questions, please type your questions or you can unmute yourself. This is how you can take a screenshot of this or grab that QRL code with your phone. That's how you get CME credit for this talk. Dr. Reddy, there's a question, and it says, can internists initiate SGLT2 inhibitors, or is this something we should refer to cardiologists? And is this something we can initiate in the hospital, or is it preferred to initiate as an outpatient?
So the answer to the first part is internists should initiate because they are the ones who deal with the diabetes. So initial research was in patients with diabetes and heart failure. So if you're starting it for diabetes use, you're simultaneously treating the heart failure too. So the answer is yes, you can start. But when you do start, there are certain things I would like you to watch for. So these SGLT2 inhibitors are also diuretics, are good diuretics. So when you start those, if they are on furosemide or torsemide or some form of diuretic, so you please watch for hypotension. If they get hypotensive, drop the diuretics. If their creatinine goes higher, drop the other diuretic. And it also, the second thing is these SGLT2s are good agents for reducing the blood pressure. So if they are on amlodipine or some other antihypertensives, you have to be sensitive. So you have to decrease the dosage of those hypertensives. And then starting in hospital versus clinic. So mostly clinic, I would say, but I'm just starting to, I'll be seeing my patient today in the hospital. So I'm planning on actually sending him home on the SGLT2 in the hospital. But usually clinic setting, and I think we do not have these ones on our formulary at Emmanuel, but you have to ask for case by case. But the answer is ideally started in the outpatient setting.
Lynn just made a comment. She said, thank you very much, Dr. Reddy. We love the heart failure clinic. And that's with 3 exclamation points. So that's pretty good.
Thank you so much, Lynn.
Anything, Dr. Reddy, that you would like to mention about our heart failure clinic and kind of your approach to working with community partners, especially internal medicine and primary care? So the focus of our heart failure clinic, like I gave you the structure, we are about 6 people in the clinic here. So myself, nurse practitioner, RN, MA, social worker. And I mean, you really need to call just that one number, And Susan is here Monday to Friday between 8 and 4:30. And Lena just started, so she's available too. And if you have any questions, you can call our general number and ask, talk to Charlie for getting an appointment. And our clinic social worker, Miranda Meng, is amazing. And just to give you an example, she got a patient a drug for amyloidosis. We'll be talking about it in our seminar number 4, which would cost $200,000+. And guess how much he is paying from his pocket now? $30 a month. So we have had, I mean, that's not an anecdote. There are other examples too. So we are very well connected. And the second thing is our focus is optimizing heart failure therapy, the quadruple therapy. And that is what is going to decrease the hospitalization, increase the quality of life, and then decrease cardiovascular mortality. So, and in the long run, it's going to translate into less number of VADs, less number of transplants, less number of decreased burden on the healthcare system. Yeah. There's a question from Susan. Oh,
So due to lack of SGLT2 on our inpatient formulary, perhaps LIMS could focus on improvement of addition of aldosterone at DC. I agree. I think when patients leave here, at least they should leave here on a combination of beta blocker, Arnie. I'm not even talking about ACE or Arnie. And I would incline towards giving an ARB only in cases where I have, I think that their insurance might not pay. And now Arnie has a 30-day free supply, so we have 30 days to process the authorization. So beta blocker, Arnie, a diuretic, and at least start the spironolactone before they leave. But when you start the spironolactone, Susan, they have to make sure, somebody has to make sure that the patient gets an appointment with the PCP, more than the PCP, with cardiology, so they can follow up on their potassium. The biggest downside to starting spironolactone or MRA and not follow the patient is hyperkalemia causing death.
Okay, can you put your heart failure clinic main number back up again on the screen?
That's the number there. So heart failure direct line 503-413-4187.
Also, there's a question in your stable heart failure clinic outpatients. How often are you checking K levels once initiating MRA?
Okay, that's a very good question. I'm glad you asked that. So based on the guidelines and the trial data, you have to check potassium before starting, and based on where the potassium is, you initiate or you do not initiate spironolactone or eplerenone. And after you initiate, the first check should be 3 days after you start the medication, then 7 days after you start the medication, then 30 days after you start the medication, then every month for the first 3 months, and thereafter every 3 months for a year. And thereafter, based on how the patient does. But initially, there is a regime you need to follow. And each time you add something or delete something that might affect the potassium levels, you have to recheck the potassium.
Wonderful. Well, thank you, Dr. Reddy, and thanks to everyone. We have another talk scheduled for next month. You should have gotten the flyer for this event, with the link to the Zoom meeting. Again, these are CME accredited. The live events are accredited, but we are recording this and we will make it available on YouTube, just like we did for the February talk. So thank you very much. Thank you, Dr. Reddy, and I hope everyone has a great end of your week.
Thank you so much for being here.